Hi, everybody. Thanks for joining us. It's at 10:03 a.m. Eastern Time. So good morning, good afternoon, good evening, everybody. We're going to get started. Terence, would you like to get started?
Yep. Thanks, Javi, for your introduction. Thanks, the entire team here. This is the 33rd program of the Journal of Hand Microsurgery, one of the best event combined with the American Association for Hand Surgery. I think to achieve great things, we need two things. One is a plan, and there's a great team. We have both today. We have delegates from all across the world, waiting to listen to this one of the vital and important topics on brachial plexus reconstruction. I thank the team here, Steve, Harvey, David, and Johnny, for making this great plan and also making this event a great endeavor. Over to you, Johnny. Over to you, Harvey, to start this program. Thank you very much for joining.
All right. So good morning, good afternoon, good evening, everybody. Thank you so much for joining us this morning. And thank you, Terence and the JHM, as well as the American Association for Hand Surgery, AAHS, for organizing this webinar. My name is Harvey Chim from the University of Florida, and I'll be moderating this session. So first of all, welcome again. Just some housekeeping points. Please mute your mics during the presentations. Cameras should be off while the speakers are presenting, but can be on for the question and answer session. And please ask your questions in the chat. We do want this session to be interactive. So it wasn't so long ago that Seddon in 1965 termed brachial plexus reconstruction as a procedure for cases of avulsion as a means to accelerating the diagnosis and being able to bring forward amputation surgery. So really, there's been dramatic improvements in the course of recent years. We have moved from short nerve grafts and non-vascularized nerve grafts really to proximal nerve transfers and vascularized nerve grafts. And really, I think the treatment of brachial plexus injuries and reconstruction has really gone back and forth between short nerve grafts and non-vascularized nerve grafts and nerve transfers and vascularized nerve grafts. And more recently, I think really distal nerve transfers and long nerve grafts have really affected my practice and then provided new options for patients. So I'll be talking about a little bit about distal nerve transfers and long nerve grafts later on. But really, there are a lot of unanswered questions in brachial plexus reconstruction, and innovation is key to advancing techniques for brachial plexus reconstruction. So today, I'm very excited to have our panel. We have 4 innovators in brachial plexus reconstruction who will be talking to us about recent advances for brachial plexus surgery. First, we have Steve Lee, who's the Chief of Hand and Upper Extremity Surgery and Professor of Orthopedic Surgery from the Hospital for Special Surgery, who will be talking to us about infraclavicular brachial plexus injuries. Next, we have Chris D from the Division of Hand and Microsurgery at WashU Orthopedics. Chris will not be able to join us today, but he pre-recorded his video and will be playing that as part of this session. Next, we have David Brogan, who is from the Division of Hand and Microsurgery at WashU Orthopedics as well, who will be talking about some of his clinical and translational peripheral nerve research. And last but not least, we have Johnny Liu from Chung Kung Memorial Hospital in Taiwan, who'll be talking about vascularized nerve grafts in total brachial plexus palsy. So I'm going to turn the podium over to Steve, who will start us off today. Thank you.
Okay, thanks so much, Harvey and everybody, for the introduction. Can everybody hear me okay? We're good?
Yes, we hear you.
Okay, very good. Okay, so I'm going to speak about infraclavicular brachial plexus injuries, the patterns, imaging findings, operative interventions, and the outcomes. And thanks to my colleagues, in particular, Anil Basha, who's given a lot of the cases and a lot of guidance on this topic. I'll be talking about the background of this topic, study aims of our cohort that we've looked at, methods, results, conclusions, and references. So there have been a few papers talking about infraclavicular injuries, but they are widely ranged and not a lot of patients. The most recent one had more, but the group that we're looking at has by far the most, and also with imaging. Back in 1985, Burge and colleagues presented 6 cases. 6 of them had axillary nerve injuries, and this is past the clavicle. So this is a different kind of subset. Muscutaneous nerve in 2, radial nerve in 2. They were treated with nerve grafts. 2 had arterial injury. Outcomes were not reported. So this is quite a while ago. In 2012, 100 patients. There are 4 mechanisms. So this is just their cohort. So kind of a smaller group of people with kind of a narrower group of mechanisms. But shoulder dislocations, axillary nerve injuries, proximal humerus fractures, and hyperextension of the arm, outcomes not reported. So you can see that this topic has been talked about, but not at great detail. Lam, Pufan, Cheng, Chuang. So Johnny, from your institution, 75 patients, minimum of 4-year. Chuang, level 4 injuries. We'll go over that in a second. And a lot of the pertinent parts, and I'm going to go over it with our cohort, are that 64% fracture dislocations about the shoulder and shoulder girdle area. And I think that's a big key point, is if you see those kind of fractures and dislocations around there, think about infraclavicular. In their group and our group, and I'll go over that in a minute, 24% had vascular injury. And that's also kind of a clue of where the injury is. In their group, the most common injuries were to the axillary nerve and the musculaneous nerve. They did nerve grafts for their group and had good, and they called good as being M3 or more for the axillary, musculaneous nerve, and radial nerve, and less positive findings for the median and ulnar nerves. Chuang has this classification for the levels of plexus injury. And in this group that we're talking about, it's level 4. They define it as cord and branches, terminal branches. 3 goes up, and you can see as you go up, 3, 2, 1, it gets more proximal. We define ours at the clavicle area, which is division and distal. The recovery rates are here. And as I had said earlier, the more proximal ones, axillary, muscutaneous, and radial, had better prognoses after treatment. For our cohort, we looked at the patterns for these injuries, location of injury, the mechanism of injury, associated trauma such as fractures and vascular injuries. And new from other series that I just presented are that we had imaging. So we have high quality ultrasound and MRI imaging. And it's really helped us to define where these injuries are, give us a good preoperative plan so we can better get ready for that surgery if needed. We also describe the interventions that were performed. So previous reports were nerve grafts, but we did a whole variety of different treatments, including nerve transfer, tendon transfers, and nerve grafts. And I'll report how the patients fared after these. Also, we had information on pre and post muscle strength testing, so the delta and their final outcomes. So from an original cohort of 1,600 patients, we narrowed down to 170 in this group. So by far the largest series. We had inclusion of division, cords, and branches. So this is at and below the clavicle. It's a little different from the Chuang 4 classification. Exclusion were supras, stretched, the entire plexus, atraumatic causes, and non-operative cases, because we wanted the operative findings to be part of the data. The average age was 31, most were men, follow-up 32 months on average, and average time from injury to surgery was 9 months. The location based on MRI and operative findings are as such. So isolated branch injury was the most common, so at 60%, and this is in line with the other previous papers, but we also got more into the specifics, looking at cord plus branch at 22% was another large group, and then isolated cord at 11%, and then combinations in the other parts. So the main take homes there are that usually it's going to be at the isolated branch and or cord, branch, or cord as far as the location. As far as the branches involved, these are the ones, and this is also in line with the previous papers that were presented and published. but most common being muscocutaneous nerve and axillary nerve. And then as far as the branches that were involved, less likely as far as radial next, and then median and ulnar. As far as cords involved, and so this is getting into even more information than was previously published, but posterior cord had the most common as far as the cords involved, then lateral, then medial cord. Regarding divisions, they were all from the upper trunk and more from the posterior part of the upper trunk, and then anterior division upper trunk. Regarding the mechanisms, this is also what generally would expect for this cohort, is that you have the majority with an MVA, so motor vehicle accident, car accident, motorcycle, that kind of injury mechanism, as can be expected. Smaller groups would be falls or other injuries, industrial injuries, and so forth. From the whole group, 73% had fractures. And this goes along with what we had been finding, is that if somebody comes in with a plexus injury and they have a lot of fractures, a lot of injury around their shoulder girdle, that was for us a big indicator that there was potentially infraclavicular injury. And if you look at that spread of the patients, the highest groups were things like the humerus was fractured, scapula, clavicle, rib. I mean, that's a really common, and many of them have all those fractured. Radius and ulna, I think, just shows the amount of kind of distal injury. A very common mechanism is that somebody, will go flying off a motorcycle and then actually have a direct blow that hits their shoulder. So they hit a tree or they hit a lamppost or something like that. And that's a very common, or they actually hit a vehicle in their shoulder area too. So it all makes sense. You have, fractures there, and you have nerve injury. And you also have arterial injury. So we had, of our group, 40% had vascular injury. This is, both those numbers a little more than the series from Changgung, but the themes are similar. When you have these injuries in that area of the plexus, then you have arterial injury and fractures. Other injuries were as such, smaller numbers here. A big key part of our cohort is that we got advanced imaging, and it helped us see where these were. And these are just some of the reports of like what they actually saw. So fascicular thickening and enlargement, 50%. So that would be where there's some sort of stretch and some changes to the nerve. Frank neuroma formation, being that there was stretch so much that, or there was sharp injury that there was actually neuroma formation, and other findings were perineural scarring and neuritis. So ultrasound definitely did see changes, and it helped us, locate them. MRI also very helpful, as you can see there, similar to the ultrasound, fascicular thickening and enlargement, 23%, hyperintensity in 23%, scarring in 13%, frank neuroma in 17%. So a lot of MRI findings, and many times in the radiologist would say that, oh, we saw these areas, and then we'd look at the EMG, there was a correlation with that, and surgery would find that. So it was very helpful for us. And what did we do for the patients? It was a big spread of things, as I think in current day, we do all these things. And in previous papers, it was more just grafting. But I think with the kind of the explosion of nerve transfers, it's really helped a lot. So we'll do a whole blend of treatments for patients. So including nerve transfers, and the majority had that, or not the majority, but 40%, the largest group had at least that. But the majority actually had nerve transfer as part of the treatment. So nerve grafting and nerve transfer, 28%, and just pure nerve grafting, 22%, and also some tendon transfers in there as well. Most common nerve transfers, as you can imagine, would be among the most common that we all do. So things like the ulnar and median nerve to biceps and brachialis, triceps axillary, very commonly done. Intercostal work to distal branches, very common as well. regarding the most common tendon transfers if needed, latissimus to biceps, subscr to EDC, PL to EPL. So, and these were, in the whole totality. So obviously sometimes these were done later. And then how did the patients fare? So their mean improvement was quite good. And if you look at the whole group, and this is for all types of treatment. So, when you think about it, in the end, what matters to the patient is just what you can do for them in totality. So that could include grafting, nerve transfer, and eventually tendon transfer. Their average post-op strength was a very useful number, for bending their elbow, 4.2, triceps extension, 4.4, deltoid, 3.9, and so forth. So in conclusion, to our knowledge, this is the largest series of infraclavicular brachial plexus injuries, and this is also with imaging data. MVA is the most common mechanism of injury, as we can expect. Isolated branch injuries are the most common pattern of injury, but there is a lot of cord injuries involved as well that we should be aware of. Many times these injuries are associated with fractures around the shoulder girdle and also arterial injury in that area. As far as imaging, fascicular thickening enlargement is most commonly seen, but also frank neuroma can be seen. And for us, imaging was helpful in identifying where these injuries were. Nerve transfer was the most common operative intervention, along with nerve grafting, sometimes in combo. And many of these patients can have at least M3 muscle strength recovery post-op. And I think that is also due to the fact that these are more distal, and we have some other proximal nerves we can use to regain function. Future directions, we'd like to have more correlations. I think I would hope that some people are asking or thinking, what's the correlation of our imaging and these other areas. We are still collecting some of this data, and also the sub-analysis of outcomes of treatment modalities between the different types of treatments, grafting, transfer, and tendon transfer. Thank you very much.
All right. Well, thank you, Steve. That was really a great talk and a huge series. So congratulations on that. We have a question from Dr. Andre Lysak from the audience. He's asking, does every infraclavicular brachial plexus injury need surgery? And how long after the injury would you perform a surgery? So I'm curious as well, in your cohort, what's the percentage of patients you actually did surgery on?
Yeah, I can't answer that right off the top of my head, but we do for, kind of pretty much all of them, unless we know they have majority of avulsions. We do use the standard, usually waiting 3 months to see what comes back spontaneously. So we will, when we first get them, and usually it's, as most people, they don't get them right away. Hopefully you're getting them within 1 to 2 months after injury. We'll get our first set of imaging, which will generally include EMG, MRI, ultrasound, and CT Milo, and then we will follow with serial EMGs and serial clinical examinations every 6 weeks. By 3 months, if they haven't got meaningful recovery coming back, and we judge that on clinical and also EMGs. If we're seeing nascence on EMGs, if we're seeing something coming back, we'll wait a little bit longer, but we try to make that decision as per usual between 3 and 6 months. So no, not all of them need them, but I'll give you that, when we do more in the series. That's a good question. What % did need them?
Great, awesome. We have another question from Dr. P.S. Bandari. He's asking, in musculocutaneous nerve injury with large nerve gaps, would you prefer to do nerve grafting or nerve transfers?
So if I have the nerves to give a nerve transfer, I prefer nerve transfer. I mean, as we all know who do a fair amount of plexus, that transfer is awesome. It's probably the best we have. It's almost, nothing's 100% in life, but it's the closest thing that I can get as far as something that's going to work for a patient. So if I can do a nerve transfer, median ulnar nerve fascicles, the brachius and biceps, and I have those, I'll do them and I can use them. But we have done long nerve grafts and they have helped as well. So, but my preference would be nerve transfer if I can.
Awesome. Thank you so much. We have 2 more questions on preganglionic injuries, but we're going to address them later on after the rest of the speakers. So I'm going to go ahead and run Dr. D's talk.
Hello. Sorry I can't join you live. Harvey, thank you for the invitation.
Can you guys hear Dr. D, just to check?
Yes, we hear him.
Okay, so I'm going to play this video.
Excited to join this great group of panelists. And let me pull up my slides and we can get started. So I wanted to talk this morning about new ways to think about the approach to brachial plexus injury in 2021. Now, I know that we have a number of surgeons that are listening to this, and this will be a slight deviation from our normal surgical technique talk. I do have to disclose research support. I'm very grateful for support from NIAMS, from the AFSH, the ORAF for our brachial plexus program. We know that plexus injuries are devastating. They have a tremendous ripple effect. They devastate patients neurologically, emotionally, and economically. Our patients go through substantial amounts of mental health distress. You can see that nearly over half of patients will have either depression or anxiety in some work that we published in JHS a few years ago. And we know that it costs a lot of money, both to the patient and to society. Now, we as surgeons tend to focus on the nerves all the way on the left, but we need to recognize this substantial impact that this injury has on our patients and their families. So here's a case example. You have a 33-year-old gentleman who was in a conveyor belt accident 6 weeks prior to seeing me. No known mental health history, seems to have a good support network. He's got a good rotator cuff, but no deltoid. He's got no elbow flexion or extension. He's got some elbow flexion that comes largely from his FCU, and he's got a good hand, in terms of his intrinsics, although he does lack function from his AIN. So in trying to understand patients with plexus injuries, we tend to try to localize the lesion, understand whether it's going to get better, and figure out how we can help them. Now, his lesion tends to localize to the musculocutaneous nerve and the median nerve, making it the lateral cord, as well as his axillary nerve and his radial nerve, localizing it to the posterior cord. Now, like it says here, his examination and his nerve studies at 6 weeks and 3 months were unchanged, so we proceeded to surgery. And here are some surgical intraoperative pictures. You can see that we explored the infraclavicular plexus, and you can see how beat up his posterior cord and lateral cord look. See his axillary nerve coming off of the posterior cord. And we went ahead and used his medial pectoral branches, knowing that his medial cord was working, and we transferred those to his axillary nerve. Now, we can see that we used a cabled autograft here as an interposition. Now, that's not ideal, but it's what we had to do to not have it under tension. We then harvested his thoracodorsal nerve and used the thoracodorsal nerve to transfer to his biceps and brachialis. We also targeted his triceps, and you can see here we did a very long sural autograft, single strand, to see if we can get something coming back through his for his triceps. So here's his overall reconstruction: thoracodorsal to biceps and brachialis, medial pec to axillary with an interposed graft, and then a long graft for his spinal accessory to his triceps. So here he is at 9 months.
Yep.
You can see pretty good elbow flexion. We'll test him a bit more. He can come up pretty well. It's not perfect. He's got some ability to resist. Now I'm trying to check his triceps. He's got some return of function there. Let's see if we can do it against gravity. Very nice against gravity. Trying to isolate his deltoid a bit. Not really getting much. He's compensating a lot through his trapezius. But we know he has a good rotator cuff, so let's see what he can do here. That's a pretty good result for 9 months after surgery, I would say. And David Brogan and I were pretty happy with ourselves, thinking, hey, we really helped this guy. But then he looks me square in the eye and says he hates it, which is completely deflating, of course. So that made me really think, how do we measure outcomes? Now, we as surgeons tend to think of things in terms of the MRC strength. It's what we are trained to measure, and that's how we assess whether we are successful as surgeons. But patients really think about it as quality of life and satisfaction. They may not care if they have an M4 biceps if they cannot feed themselves. So then we look at some of our PROMIS scores that we obtained in this patient as part of his normal clinical care, and you can see that his physical function compared to before surgery and after surgery at 9 months when he had this video result really hasn't changed, but he has gone through quite a bit of depression and anxiety. You can see that we have an excellent surgeon graded score. I thought he was great, but he rated his function as unchanged, and he had unchanged depression and actually worsening anxiety, which is very, very challenging to deal with. So we as surgeons tend to have tunnel vision. Among the 88 studies that were included in the meta-analysis that we did a few years ago, only 5% reported quality of life. What we see as surgeons is muscle strength, and what matters to patients are things like quality of life, activities of daily living, happiness, and satisfaction. So we need to change the way that we think about this. We need to measure outcomes that matter to patients. Now, in general, we like to think of the predictors of outcomes after BPI as broken down by the injury itself, where they're cared for, who takes care of them, and then some patient factors. We know that severity of injury matters. The number of levels that are involved will dictate your options. Hand function's a big thing, and in this patient, we were fortunate enough to have a good hand. And then avulsion injuries tend to do worse. We know that pain is really difficult to treat and can really be the difference maker for many patients, but is incredibly common. And the limits of neural regeneration, I don't need to tell this audience more about. Unfortunately, delay in the United States is often, referrals are often delayed in the United States, with almost a third of patients having surgery over a year from injury, which is a bit crazy, but we know that this happens. And we know that there's a delay when the patients are coming from smaller hospital systems. Patients are often frustrated when they're seeking care. They have a hard time finding surgeons and information about treatment. And in the United States, we have to deal with the insurance status of patients, which oftentimes is in flux because their insurance is many times tied to their employment. This group knows that there are shortcomings in our literature, and there are shortcomings in how we're trained. A lot of what you're trained to do will depend on who you train with, and if you don't seek out additional experiences, you may not have the full armamentarium. And this is from a paper by Alan Belsberg. Experienced surgeons disagree in important ways for the management of brachial plexus injury, and we demonstrated that when we interviewed surgeons using some similar scenarios, case vignettes, and found that surgeons oftentimes don't come to a consensus. And then technical skill is an important part of it. This audience doesn't need any reminder of that. We know that mental health matters to patients, and then patients who have a sense of purpose will do better. Coping skills and personality will influence their outcome. And patients have told us that they wish that we had taught them more about the course and the journey, and they want to be coached about it. And then most importantly, setting expectations is critical. Now, we came to all these conclusions through a series of qualitative interviews with our patients. So let's go back to this patient. We know from a plexus perspective, we were fortunate in that he wasn't having terrible amounts of pain. He had an infraclavicular injury without any sort of avulsion, and he had a good hand. This patient came to our ED for his initial injury, so we were able to get him referred quickly, and we got him to the OR pretty quickly, which was great. I think Dr. Brogan and I did a nice job in terms of providing a reconstruction that has a nice chance of working, but I think this is where we fell short. We didn't engage him well enough in terms of education, checking in on his mental health, and then equipping him to go through this process and understanding the appropriate expectations. So it comes down to the fact that this is more than just nerve surgery. And the nerve surgery is incredibly hard, but we need to take a broader perspective when we're trying to figure out how to help our patients with plexus injuries. We need to assess outcomes from different perspectives. We need to improve how we educate our patients and coach them through this process, and then continue integrating multidisciplinary care. One of the big pushes that we have here at our center is that we're leading this prospective longitudinal assessment of nerve trauma, or PLANET study, in which we and these 4 other centers, HSS, OrthoCarolina, Vanderbilt, and Johns Hopkins, are collaborating for a multi-center prospective cohort study in which we will assess the same outcomes at the same intervals. Now, we'll include normal kind of patient, surgeon-graded muscle testing and range of motion, but we'll also include a plexus-specific impact of BPI questionnaire that was developed at HSS, as well as the DASH, the SF36, and PROMIS scores, which I think will make a big dent in terms of how we understand what patients go through. And this will be nice because it's prospective, multi-center data. So let's go back to our patient here. This is how we would typically look at this patient and assess them. Now, you can see the treatment listed here. He has a pseudonym also listed. And this is how we would assess them normally with just manual muscle testing. I think this is what we're missing a lot here. And I think where we want to go is something more like this. And we're well on our way now. We want to assess what they're doing with their life, what their social support is like using validated questionnaires. We want to check their muscle testing because, of course, that is important. But we're also trying to get towards using motion capture to look at how they're actually functioning. We want to incorporate these PROMIS scores for pain interference, depression, anxiety, and multiple time points. We want to see if they're actually using their reconstructed limb, and that's through using wearable devices, which we're doing some pilot work on now. And then we want to look at their plexus-specific outcomes questionnaires from before they start to where they end up at 1 year, 2 years, and 5 years. So this is a kind of a comprehensive dashboard to really understand how a patient is doing. And I want us to get there. I'm very fortunate to work with David Brogan, who you'll hear from shortly. He is a fantastic partner, both in surgery and in our investigations, and no talk would be complete without mentioning his tremendous contributions to our team. So thank you for your time this morning. Again, I apologize that I can't be there in person and live, but I hope that you find this a useful talk, and I look forward to hearing any follow-up. Thank you.
Okay, well, thank you, Dr. D. And speaking of Dr. Brogan, our next speaker is Dr. David Brogan from WashU. So please go ahead, David.
Thank you so much, Harvey, for the opportunity to join this group and have a chance to share some of our work today. Certainly a very distinguished panelist, and feel fortunate to be among their ranks. My talk today is going to focus more on what are the innovative things that we can do from the lab perspective and get bench to bedside to hopefully help shift our recoveries and move the needle in terms of how our patients are able to improve after surgery. So these are my disclosures. I have some Department of Defense subaward and various industry clinical trials currently ongoing. And my other disclosure is that I'm an orthopedic surgeon, but my interest in my clinical practice is focused on the salvage of mangled limbs and care of complex nerve injuries. So a lot of microsurgery coverage, free functioning muscle transfers, things of that sort. And I'm very blessed that I have really world-class partners, all of them that you can see here, each giving a different perspective and unique capabilities, and really just it's a wonderful group to learn and grow from. And then finally, as Dr. D said, he and I are helped to run the peripheral nerve practice in our orthopedic group, and he is a tremendous partner in terms of his clinical acumen and research skills, as well as his operative capabilities. And so what I want to talk about now is that, Chris gave a wonderful discussion about kind of how our lab focuses on evaluating outcomes after peripheral nerve surgery. But I'd like to also show how we look at the lab side of things. And so the Nerve Research Lab really has two objectives. First off, to characterize the degree of nerve injury intraoperatively. And we do this, and we're looking at utilizing optical probes with near-infrared cameras, similar to what we have with the SPY machine. And then secondarily, we're looking at ways to hopefully mitigate the effects of Wallerian degeneration. And we do that by manipulating a protein, SARM1, which has recently gained some traction out of our genetics group. And so I know that this group doesn't need to know that obviously we face challenges with intraoperative evaluation of nerves, both when they first come in acutely and then also when they're subacute or chronic injuries, and trying to understand where the level of injury is, how severe the injury is, and then what we need to do to get back to healthy nerve, if anything. And so this is a patient who came in with a gunshot wound to the sciatic nerve. We had an ultrasound here, and you see that obviously it's got some sort of discontinuity or concern for discontinuity in the nerve itself. When we eventually evaluate this intraoperatively, really our only ability now is to bread loaf it, to cut into the nerve and to evaluate fascicles under the microscope and try and understand where the degree of injury is by looking at the fibrosis and looking at the architecture of the fascicles themselves. This is suboptimal for a number of reasons. It's time consuming, it's relatively inaccurate, and it's very subjective. What we'd like to move towards is the ability to have more objective evidence that doesn't necessarily involve even cutting into the nerve. And so we're hoping that we see that this might be one solution. So this is a patient who had a grinding injury, an avulsion of his forearm from a corn auger, which is a farm implement common here in Missouri. And he also had a disruption of his median nerve. So as we were using a latissimus muscle to cover his forearm, we gave indocyanine greens nonspecific tracer, and you can see that clearly there's a difference in the uptake and fluorescence of the nerve in the more healthy areas that are less injured and the more traumatized areas that have really poor fluorescent uptake, signaling poor blood flow to that part. And so that was really the impetus for a grant that we received from the Hand Society, looking at the evaluation of laser Doppler flowmetry in a rat sciatic nerve model to see if we could understand better what the implications of a crush injury to a nerve are in terms of blood flow, and if that would correlate to the amount of injury itself. And so what we did is we crushed a rat sciatic nerve with different degrees of crush, And then we put it under laser Doppler flowmetry before the crush, and then immediately after, 6 hours after, 2 weeks later, and even 6 weeks later. And then we also assessed how that correlated to the functional recovery of that rat in that specific hind limb. And what we found is that in the controls, you can see here, really the difference between the initial reading and the 2-week reading is not very significant. But when you have a crush injury, what you see is that there's a significant hyperemia, which is actually somewhat counter to what we thought. Initially, we thought that we'd see a decrease in blood flow, but really this is probably reflective of the inflammatory response in the breakdown in the blood-nerve barrier. And this has been shown with MRI, utilizing 3 Tesla and higher MRI to look at nerve recovery. And so when we quantified this and compared it to the outcome of the muscles, what we found is that at 6 hours after the crush, there was really no significant correlation between the degree of injury and the laser Doppler flowmetry. But if you started following out for a longer period of time, what actually ended up happening is that the nerves that recovered had a return of essentially normal blood flow within the nerve. The nerves that had not recovered or were more severely injured had persistent hyperemia, as you can see here, elevated blood flow at 6 weeks, whereas they also had poor return of their tibialis anterior muscle function. And again, this probably represents persistent ongoing remodeling and inflammation within the nerve and persistent changes in the blood-nerve barrier. What we also found from that study is that this correlated well, the degree of injury correlated well with the expression of MMP9, matrix metalloproteinase 9, which is a peptide or proteinase that is really a marker of inflammation. And what we found is that the initial expression of MMP9 correlated well with the degree of crush, even at 6 weeks, and the amount of recovery at 6 weeks. So by looking at this, we could predict relatively poor recovery by assessing how much MMP9. We know that that makes sense because this has been found by other labs, that Schwann cells secrete MMP9 after axonal injury, and it's utilized to mediate the TNF-alpha macrophage recruitment that nerves use to help themselves recover. And transcriptional expression is also modified. The mRNA is upregulated by 200-fold in an injured nerve in terms of expression of MMP9. So this makes it a useful target for us to look at potentially ways to predict nerve injury intraoperatively. And to be able to do that, we would need to have a probe that is capable of assessing the amount of MMP9 in surgery. And the way that we went about looking at this was to create a near-infrared fluorophore that is sensitive to the peptidase or the proteinase function of MMP9. So we make a peptide sequence, we assemble it that is sensitive to what MMP9 normally breaks down. And we use that to link both a near-infrared fluorophore, a probe that will glow on its own, and put it next to a quenching probe. And through this mechanism called free resonance energy transfer, when they're closely associated, this probe will be masked and you won't see anything. When the MMP9 comes in, it will basically dissociate this peptide sequence and then unmask it, and you have a glowing fluorophore. So in the presence of MMP9, we'll have the ability to see a glowing fluorophore from that. So we developed this MMP9 sensitive probe, and we then tested it in a rat model. We would cut or essentially crush the nerve, and then at 6 hours, 2 days, and 2 weeks, administer our probe and see what we would get. We also then look at muscle function and conduction velocity. And what we see here is in the control, relatively poor fluorescence after administration of the probe. In the crush injury, we have an increase in the crush nerve in terms of fluorescence of the probe. This is what it looks like with a heat map overlay of the white light. This is the bilateral sciatic nerves. This part has not been injured, this nerve, and this part has been the zone of crush. You can see it glowing after administration of MP9. When we quantified this, we found that the effect was most noticeable at 6 hours after the injury. And we also found that a non-specific probe also had a significant increase at 30, 60, and 90 minutes after administration in terms of the emission of the probe. So we've also looked at some additional new probes that are currently under evaluation in our lab. And we found that we can actually predict this and show injury to the nerve even more impressively with a higher signal to noise ratio for the zone of injury here, compared to this is an uninjured nerve with a black background. There's really no fluorescence from that nerve at baseline. Clinically, this seems to work as well. We've not administered the new probes in humans yet, but even with just non-specific probes, we can see some uptake. So it is encouraging that we can get fluorescent probes into nerves, and hopefully that will be our avenue for further investigations. And finally, to kind of summarize or to close, I'll talk a little bit about our kind of parallel track of trying to minimize the impact of Wallerian degeneration. I don't have to tell this group that obviously Wallerian degeneration poses a significant problem, and especially in terms of regaining hand function after a brachial plexus injury. After a nerve injury, we all know that there's this very established sequence of events where a nerve is injured or cut, and then there's this execution phase where Wallerian degeneration sets in, and you have these calcium influxes from kind of the catastrophic disassembly of the distal nerve. That is controlled by SARM1, which is essentially the central executioner of Wallerian degeneration. Working with our partners in the genetics department here, we were able to create gene therapy utilizing an AAV vector or AAV plasmid and injected rats to create a dominant negative or SARM1 dominant negative rat. So essentially knock out the majority of SARM1 function in our rats. And we also utilized a control vector that just had a GFP protein. And then we cut and repaired the sciatic nerve and then evaluated how they did with different functional assessments at 2 days, 2 weeks, and 6 weeks. And what we were able to demonstrate is that in our dominant negative, when we were able to inhibit SARM1, even at 2 weeks after cut and repair of the sciatic nerve, we were able to reestablish a compound nerve action potential, which looked remarkably similar to the control nerve that had never been injured. Compared to the uninjured side. When you look at our control plasmids, so this is essentially a wild type rat that has had a cut and repaired nerve. There's essentially no compound nerve action potential at 2 weeks. It has not recovered enough to have that. Whereas in the SARM dominant negative, it almost looks the same as if it was never injured. So this was very encouraging. We also then looked at our axon counts. We're able to demonstrate that at 2 weeks, even after repair, we had a significant return or maintenance of myelinated axons. This is the myelinated axon here. The black is the myelin. These are the individual axons. Whereas compared to a control plasmid, which is essentially the wild type, there's really very little healthy axons in there. At 6 weeks, the control started to catch up, but the SARM1 dominant negative has, again, an abundance of healthy myelinated axons. And when we looked at this quantitatively, we saw this as well. Again, a significant retention and improvement in terms of myelinated axons at just 2 weeks. So this is encouraging, and we think a very promising avenue for further development. Small molecule inhibitors are under development, and initial studies published just a month or two ago have shown some efficacy of this in a murine model. So in summary, our NIR molecular and infrared molecular dyes hold promise, we hope, for future intraoperative functional imaging of nerves. Even now, alterations in blood-nerve barrier may represent a way that we can exploit physiologic changes to get information intraoperatively. And I think that the manipulation of the SARM1 axis holds great promise, hopefully, for preventing Wallerian degeneration and potentially restoring function to our patients in a novel and exciting way. Future directions, we are continuing to develop probes in addition to ones that are able to evaluate nerve. We're looking at some that focus on muscle. That's the subject of a grant that we're submitting this week. We also have a study underway looking at the combination of PEG fusion and SARM1 inhibition on nerve recovery. And we're developing a model to look at ways to hopefully mitigate neuropathic pain using some of the techniques I've described before. Thank you again for the opportunity to talk, and I'm happy to answer any questions.
Great. Thank you very much, David. That was a great talk, and I would love to hear more of your future work, as you do it. It's really, really exciting stuff. Next, we have Johnny Liu from Taiwan, who'll be talking to us about vascularized nerve grafts.
All right, do you guys see my screen?
Yes, we see you.
Okay, all right, I'll get started. Thank you so much, Harvey and Terrence, for this opportunity. This is such a prestigious panel, and I think what David just said was very stimulating for me. So anyways, I'm going to talk about vascularized nerve graft in panbrachial plexus palsy. It's a little bit different from the previous topics. I have no conflicts of interest to disclose. Basically, the acute panbrachial plexus strategy at Chang'an, speaking on behalf of David Tron, Tommy Chang, and me, we explore all plexus, whether or not it's a total root avulsion or it's having a 1 root, 2 root. I think instead of having a fixed algorithm on using what nerve for what function, this exploration determines how we plan our donor nerves, and either for this surgery or any future palliative or secondary surgeries. It's important to know what recipient nerves you want to, given that the paucity of donor nerves. And then always having a functioning free muscle as a backup. And this means trying to reserve or preserve a specific donor nerve in case you need it. So for brachial plexus, I'm going to divide it into two topics with available routes. It's important to have this concept of knowing if your root or spinal nerve, as David would say, if it's ruptured or avulsed. If it's avulsed, and it means the stump is not usable, as you can see in this picture over here. And if it's ruptured, it means that it's a usable stump. And this is very important in our planning, especially with the vascularized ulnar nerve grafts. And in a paper that's published in radiology, our team of radiologists devised a classification looking at the rootlets, specifically the ventral rootlets and the dorsal rootlets, and using very high magnifications in a combination of different views to help us classify preoperatively whether this root is worth going for or not. And this has very high correlation of what we find intraoperatively. And having the right donor means that you can decide what recipients you want to use. And it's important in the panbrachial plexus to have your priorities. And previous papers from Dr. Sukovsky and also from Dr. Bertelli has said that having your nerve grafts going very distal, close to the target muscle is important to get good results. And this is from Dr. Bertelli, where he said using non-vascularized serial nerve graft from C5 going all the way to the muscocutaneous, averaging 17.4 centimeters, he was able to get 20 out of 22 M3 to M4. That for us is very difficult. So what we do is actually use the vascularized ulnar nerve graft. And it's important, again, to prioritize your strategy. Elbow flexion is always the most important, followed by shoulder and finger flexion. This includes sensation, and then any types of extension, which we're actually gradually trying to get more focus on. So for us, it's always, if you have a root there, C5, we always try to hook it up to the muscocutaneous nerve. But again, having this backup in your mind. For shoulder, as anyone, spinal accessory is ultimately the nerve that most people use. But then we prefer to use the phrenic more, or any of the roots available. And for finger flexion, this is where we use the vascularized ulnar nerve graft, again, either from C5 or contralateral C7, which I'll bring up later. And then for elbow extension, this is any of the remaining, but this is not obviously a priority compared to the other functions. So the vascular ulnar nerve graft, it's indicated when you have any lower plexus avulsion cases. And this is very, very important that by 4 to 5 months, you have nothing seen in the hand, and it has to be nothing before you harvest it. And the ulnar nerve has been described to have multiple perfusion or multiple donor vessels involved. And the vessel that most people like to use is the superior ulnar collateral artery. For the vascularity of a nerve graft, it's important to know where the vascularity comes from, whether or not it's a serial nerve graft or a vascularized nerve graft. If you have a accompanying nutrient vessel, that's the best. It's like a free flap. But then it can also come from your stumps or from your surrounding environment. And what the vascularized nerve graft provides is trunk grafting instead of multiple cable grafting. The distance can go beyond 10 centimeters, sometimes up to 20 centimeters. It can be used in a scarred environment, even under a bit of a compression. There have been people that have described that it can be used in a subacute setting, but I think if you're going to do this, you do this right. You always do this in an acute setting, if possible, to get the maximum results. Dr. Bertelli in 2010 published their results where they said using the pedicle vascularized ulnar nerve graft, similar to what Dr. Gu had described in the 80s. And that they didn't get good results. Nothing was greater than M2. For us, it's important that we don't just use the superior ulnar collateral. We harvest this entirely as a free ulnar nerve graft. And it is important you get the middle of the nerve graft where the ulnar artery comes in and can innervate both ends very easily. And again, we don't do any pedicle. We don't turn the most distal part going to the proximal. We treat this as a free ulnar nerve graft. And you can harvest it up to 20 centimeters, 25 centimeters if necessary. And you can obviously harvest the dorsocutaneous branch, which allows you to reach 2 targets. And so this is in cases where you have a nice C5, and it has to be a nice ruptured we will use the vascularized ulnar nerve graft to hook up to the median nerve, then muscle-cutaneous nerve infraclavicularly. And here is where you, after the MRI gives you good diagnosis with the stump of the C5. We use this long nerve graft with a nice vessel, and this is how we would prepare it placed underneath the clavicle. And there's no multiple cables. Itself, it's a naturally designed trunk graft where you can reach from the C5 all the way to the median nerve and muscle-cutaneous. And this is one of the results that you can see where you have very strong elbow flexion. At the same time, you have some sort of a finger grip. It may not be as natural as intended, but definitely you can see that finger grip coming in, which can help the patient. With a strong elbow flexion, the patient's able to supinate quite easily. Again, the supinated elbow flexion, and sometimes quite easily with ease. It helps if you have a wrist arthrodesis to kind of fix it, to kind of fixate it, to have stability. And then having that finger movement, some would argue that having that finger movement is not really beneficial to the patient. But I would argue differently For this patient, you can see with the grip of a ball or a grip of a bottle is able to pronate and supinate easily. Again, use this hand to have sufficient grip of the water bottle and to allow better. And then this is how they can help them with daily activities, such as eating ice cream, holding a phone, playing an instrument, or even riding a bike. Sorry for the noise distractions. In cases where you're lucky enough to have 2 rupture roots, we also try to use our vascularized ulnar nerve graft efficiently, dividing this up into 2 nerve grafts, and then trying to restore not just the muscle-cutaneous and median nerve, but going after the posterior cord to the radial nerve and the axillary nerve. This study is still ongoing. We have seen some promise with the triceps recovering, but I'll go over that once we get more results. And the next part is about contralateral C7. So in panbrachial plexus palsy, we have total root avulsion. Cases such as this, total palsy, but then you see the MRI, you don't see any viable roots that come out from the C5 or C6. Our inclination or our preference in the strategy-wise in the acute cases is not do the DOID technique, but try to do the contralateral C7, reaching from the contralateral neck. Again, we do this subcutaneously, so we do not do the similar way that Dr. Wang from China described using the primary coaptation. We still prefer to do this under ease in a subcutaneous tunnel rather than retroesophageal. And this is how we would use it, where we use the vascularized ulnar nerve graft from the contralateral C7. And our primary aim is to go after the median nerve. As for the muscle-cutaneous, you would try to use the intercostal. You can also hook up this to a 2-target, but usually by doing this, you have a not as good outcome on the median nerve. I think the controversy with using the contralateral C7 has always been the donor site morbidity. And people are talking about, is the functional outcome worth it? And I think the paper that obviously has been giving us the most impact was from 2015, the systematic review by Dr. Kevin Chung in PRS. And I think it was a very well done study. In terms of donor site morbidity, what they found was that the index finger had a high incidence of numbness or sensory abnormality. And in terms of muscle wise, they found that the triceps was 35% was affected. But again, I want to emphasize that given the wide spectrum of the outcomes provided, this is not a meta-analysis, it's more of a reporting of the systematic review of the articles. For us, we prefer to use the entire C7, and the finger numbness that's present, that's described by the patient, is permanent. There's no way around this. But it serves a purpose. And this is how we explain to the patient, which actually most patients, I would say almost 100% of our patients can accept this, is that it's an alarm. Anytime there's a touch or anytime there's any harm or damage to the injured hand, the healthy side is going to light up, and the healthy side is going to say something's touching me. And I think having that protective sensation is very important. This is Dr. Gu in a meeting that I had the privilege of meeting him, and he talked about the contralateral C7, and you can see that the posterior divisions were most of the motor effects, and the radial nerve obviously has the most effects on it. For us, again, I just wanted, as you can see here, that this shoulder, elbow, finger flexions are not affected as from what we see, and we have up to 230 patients. Elbow extension, again, there may be some temporary weakness immediately first month post-op, but permanent, it's again not present when we see them. And there has been papers that published from my teacher, David Brogan, looking at the contralateral C7. I think he was also one of the pioneers that initiated this. There was no permanent loss of shoulder, elbow, or finger flexion or extension that was found from our study. We did find that there was an absence of this triceps reflex that had been mentioned, but again, I don't think this is detrimental to healthy, to their daily activities. There are some tips that we have found that if you stimulate it and you see some very significant strong wrist and finger extension, you might be a bit more careful, need to be a bit more careful. But again, this comes back. And so from the study that published in JBJS from Dr. Shin notes that using the hemi-contralateral C7 and a pedicle vascularized on a nerve graft, their outcome was not worth it as it had been assumed. Again, this is another study from Thailand and working with Dr. Spinner from Mayo, again, that they found that it was not worth it to have that. They found that most of them retained had M2 recovery, but not M3. But again, this is a pedicle vascularized on a nerve graft. For us, this is doing a contralateral C7. This is a patient of mine where I had total root avulsion. And you can see that the free vascularized on graft from the contralateral C7 has that finger flexion that you can see. This was before wrist arthrodesis. He had that pronation, strong pronation that he can control. But again, the criticism behind the contralateral C7 has always been that it's unnatural. And so that's something that the patient needs to train. And so that's something that we do need to talk to. And I think with more standardized outcomes, it's something that we probably need to show more of. Again, this is another case where we did a contralateral C7 to median nerve. And you had the shoulder movement. Elbow comes from the intercostal nerve. But then from here that you could see, you could see that finger flexion. But again, the patient, he needs that induction movement to really get a very strong grip. But again, whatever helps for these patients to get a grip to help hold an object is important. Another case where we had the contralateral C7 going into two targets, as you can see here, elbow flexion, and then some finger flexion, which may not be very significant, but again, with training, can help with daily activities. And we have taken the chance to use accelerometry, these devices that we worked with, and looking at the time that per day that the arm moves, or the vector, the magnitude that the arm moves. And in 29 plexus patients, this was a study that we worked with Michigan. We're very fortunate to work with Dr. Yang, Susan Brown, and Dr. Kevin Chung, where we looked at our 29 plexus patient, where more than 55% had used a contralateral C7 as a donor. These are pretty much the original, the traditional outcomes that we see. But what we found very interesting, that in this whole group, in terms of VT, the average VT, or average time that the patients use these injured limbs, was 0.54, which is very nice, because it means that they use them more often than not. And more than 55% had VT greater than 0.5. Obviously, for the magnitude, it's low. It's 0.3. But again, for these plexus patients, anything that has working that can help their daily activities, it's important. What we found further even more using statistics is that patients with contralateral C7 perform similar to ipsilateral C5 in terms of VT. And we had these really good outcomes with ipsilateral C5. But what we found was that these patients with contralateral C7, they're using these limbs more often than we had assumed too. Anytime you have a poor outcome, it's always important to preserve that nerve that I had mentioned. And spinal accessory for us is so critical that we want to preserve it for any, because pen plexus, again, you're doing all these multiple reconstructions. No one can guarantee that you have these absolute tremendous outcomes. And there comes a time when you need to salvage. And this is where we use the gracilis, using the spinal accessory nerve to help whatever is needed, elbow flexion, wrist extension. Yeah. And again, you can use this functioning free muscle. Another thing is when you don't have that finger flexion coming out, especially from contralateral C7, when you don't see that optimal outcome, you can again use the functioning free muscle and then inset it and use the nerve downstream from the median nerve that's been previously neurotized by the vascularized on nerve graft from the contralateral C7. And again, I get these results from the functioning free muscle. But again, the criteria, the critical point that you have to recognize is that these patients have to have loose joints because most of them don't have a wrist or finger extension. And so this is our strategy. I know we're running out of time, but again, I think planning is very important. Never just do a strict set of strict set of combinations of nerve transfers just for all your total plexus patients. Always try to work around them. I encourage everyone to explore the neck. It's easier than what it's been assumed. And then always have a backup plan. And so we use the vascularized on nerve graft. And obviously these don't come as fast as the nerve transfers. And so even at post-op 8 months, you don't see these very significant finger movements or elbow flexions. And you might feel a bit discouraged, but takes time. And with these vascularized on nerve graft, the interesting thing is that they come about actually after the first year. And I think that first year is actually very difficult for the patient and for the surgeon itself. This is at the first year. This is me sounding excited, so I'm going to turn that off. But again, you can see that finger flexion coming from the median nerve, and you can see that strong elbow flexion coming, and it's just 1 year. So thank you so much. My name is Johnny, and feel free to contact me. This is my email. I use Instagram a lot, microneurosurgeon. So thank you for the opportunity today. Thanks.
Great. Thank you, Johnny. That was amazing as usual. Amazing results. I don't think anybody else can reproduce that.
Thanks.
Yeah, I have just a few slides. So I'm just going to run through my slides very quickly, and then we'll move on to the discussion. Okay. So I want to talk a little bit about two things that have impacted my practice really in the recent years. And these are distal nerve transfers and long nerve grafting. So there's this phenomenon of the T1 hand, which was described by Bertelli, where C5 to C8 is involved, so that the only thing that remains is wrist flexion, finger flexion, and intrinsics. He described the AIN to ECRB nerve transfer. And really, this is a really straightforward nerve transfer, and it works very well in my experience. The distal AIN branch to the pronator quadratus is moved upwards to reinnervate the ECRB. And you can get really good results. So this first case, the 3-year-old male who had extended C5, 6, 7 injury as well as posterior cord, and mainly really only wrist and finger flexion. So we explored him. C5 was transected, C6, 7 avulsion, and posterior cord was thickened but intact. And we did pretty standard reconstruction, explored the plexus with cable grafting, SAN to SSN, Oberlin, FCU to triceps, and AIN to ECRB. And this is an AIN to ECRB. It comes up pretty nicely, and you can swing it to reinnervate the ECRB branch. And this is his result at 22 months. Very strong anti-gravity wrist extension. Okay. So in the past, before this was described, we're not really able to offer much for him, but this has really been very useful. Another patient, older guy, 63-year-old male involved in an MVC, recovered wrist flexors, finger flexors, intrinsics, but everything else really nothing. An MRI showing a partial thickness tear of the postganglionic C6 and C7. So we explored this plexus. The C5, 6, 7 was in continuity and did the AIN to ECRB. And then here you can see the plexus, a bit of scarring, but really not too bad. And then here again is the AIN to ECRB. And this is his result at 9 months.
Wow. Now do that, yeah.
So really not as strong as the other guy, but pretty much getting there.
Wow. Now do that.
And For lower plexus injuries, two nerve transfers that have really been amazing for me in my practice are the supinator to PIN and ECRB to EIN. And really this also comes out from Dr. Batelli, who's really an innovator in this field. And it's really easy to do. On the left side, you can see the exposure of the median nerve and the IN has been dissected out. And then on the center image, you can see the PIN has been dissected out as well as the supinator branch. And there's another one behind it. And in this particular patient, we did an ECRB to AIN nerve transfer as well as a supinator to PIN to restore finger flexion and extension. And then I want to talk a little bit about long nerve grafts. So Johnny talked a little bit about this, and I really think the pendulum has swung back towards long nerve grafts, which are targeted for, especially for complete brachial plexus injuries. And these are two of the important papers that have come out in recent years from Dr. Batelli as well as Sokolovsky about the efficacy of long nerve grafts. I just have two quick cases to present. This is a case of complete brachial plexus injury, 17-year-old male, motorcycle accident, left total BPI, no movement in the left upper extremity, and really only spinal accessory nerve is intact. 1 month post-injury, he came to see me. So a pretty standard complete plexus injury. And the MRI showed a probable defect in the postganglionic C5 and a defect in the postganglionic C6 with a proximal neuroma and thickening, suggested avulsion of C7, C8, and T1. And you can see on the MRI, you see it very well. You actually see on the right side here, you see the large neuroma and continuity that are reading from C6 as well as the gap in the postganglionic region. And up here is supposed to be the C5, just above that. And here you can see the pseudomeningocele down here involving C7, C8, T1. So when we explored him, we found that C5 was in continuity. Actually, it was more of a post-fixed plexus, where the C6 and the C7 gave rise to the upper trunk, and a very large neuroma and continuity from C6. So as mentioned, C5 in continuity, but really didn't stimulate at all. C6 in neuroma and continuity, C7 transaction, C8 and T1 pseudomeningocele. So we perform a long nerve grafting, 9.5 centimeters from the C6 and 7 to musculocutaneous, spinal accessory to suprascapular nerve transfer, as well as a long thoracic nerve to triceps nerve transfer. And this is the serial cable graft going from C6 to 7, going to the infraclavicular region, spinal accessory to suprascapular nerve transfer, and long thoracic to triceps. And this is his result at 13 months. He did recover amazingly, shoulder abduction.
Try and lift it up all the way. Okay.
And here he is carrying a bag.
And just do another. Move your shoulder. Okay.
And this is his elbow flexion result.
Flex your elbow for me. Okay, and go down and up again. Go ahead.
And here he is, lifting a bag against resistance. So I really think this works. And at 22 months post-op, even better shoulder abduction and good elbow flexion.
Yeah, please. Just bend your elbow. Yep. Okay. And then lift it up as high as you can. Okay. And then see, and then try and bring it.
So this next case is actually a case of BPBI, but it kind of illustrates the same principles related to long nerve grafting. So 4-month-old male, right BPBI, really presented with only some shoulder forward flexion, no significant elbow flexion, and really nothing else. MRI suggested C7 to T1 root avulsions explored at 5 months of age. So we found that the C5, 6, 7 roots were neuroma and continuity with a C8 and T1 root avulsion. And for these BPBI patients, I do intraoperative electrophysiology, and we found that there was conduction from C6 to the axillary nerve, suprascapular nerve, and lateral cord, but no conduction from C5. So we resected the C5 back to viable fascicles, and then grafted from the C5 to the medial cord. So I guess 4 centimeters in a baby is considered long, not in adults, but it illustrates the principles, side-to-side grafting from C6 to the musculocutaneous nerve, and then end-to-side spinal accessory to suprascapular nerve transfer. So 3.5 years post-op. This is his hand function. He has excellent shoulder, elbow. Really, I think this really makes a difference because he's using affected hand as well. His good grip. And if you look at his hand,
your wrist for me.
Do it like this.
Yeah,
Okay.
he's able to extend his fingers and wrist pretty well. And here he is
Hold it up, make a fist like that.
making a fist.
Okay.
So it's very difficult to get these videos because as any of you who work with kids know, it's almost impossible to video kids. But I really wanted to show these cases because this has really helped my practice. So I really think that improvements in MRI, distal nerve transfers, and long nerve grafts for me have really made a difference in outcomes for for patients. So I want to end by just giving a little shout out for the hand journal. This hand journal is the official journal for the AAHS. So please consider submitting your work to this journal as well. It's indexed in Medline and ProQuest. We have a regular online journal club every 3 months where we talk about interesting topics in hand surgery. The next one is coming up on November the 16th, 8 to 9 p.m. Eastern time. We'll be talking about distal radius fractures. And we have a great group of discussants. We have an expert, and we'll be talking about 2 interesting papers that recently came out. And again, registration is free, so please consider joining us. And AAHS is on social media, so please consider following AAHS as well. And finally, the AAHS annual meeting is coming up in the winter in Carlsbad, California, really a beautiful area. So please consider submitting papers and joining us as well if you can. So thank you very much. Love to welcome any questions. All right. So again, thank you so much, everybody, for joining us. We have a bunch of questions in the chat. So we're going to try and get to all these questions. But I really want to start out by posing a question for the panelists. So, you know, I think for this webinar is entitled New Frontiers in Brachial Plexus Reconstruction. So, I mean, for me, I think the most exciting things in recent years is really distal nerve transfers and long nerve grafting for me. So I'd love to hear from the panelists. What do you guys think are the most exciting things that have helped your practice? Johnny, you want to start first?
Okay, thanks, Harvey. I think distal nerve transfer is something that, aside from the routine, you know, double fascicular transfers or the intercostal and the MC, and I think something that you brought up, the ECRB to IN or vice versa, I think that's something that I've been trying to get more experience on. But really for us, for this, our team, it's been MRI. We did used to do a lot of, or we tried doing intraop SSEP, and it hasn't really worked for us. There's been quite of a percentage of false positives. So that's why we turned to imaging, and I've been very fortunate. It definitely has helped someone who's a young surgeon like me. We do still routinely explore a lot, but just having that combination of MRI with us, with the intraop exploration, really helps confirm and allows me to be very confident when I use the vascularized on the nerve graft. Yeah,
that's great. Steve, I'm not sure if you're still on the line, but if you are, do you have any thoughts on this topic, areas that have really helped your practice? Well, I guess Steve may join us. I see his video is off. How about you, David? What has affected your practice or really contributed to your practice in recent years?
Yeah, I would agree with Johnny. Certainly distal nerve transfers in terms of the therapeutic side. In terms of the diagnostic side, I think that's kind of what's really ripe for more innovation, and what we probably need to find ways to get a better handle on in terms of early diagnosis. We have a lot of avulsion type injuries, not so many stab wounds or sharp. And so trying to understand, do we intervene and how fast can we intervene will really, I think, help change the prognosis for these patients. So MRI, I agree, has been very helpful for us. We don't routinely get CT myelograms anymore. We almost all patients get an MRI of the brachial plexus. And that's been pretty reliable. It's a little bit more difficult to interpret. I think it's good at seeing root avulsions. It's hard to know what to make of. You often see you'll see this enhancement of the cords or the trunks. And it's hard to know what to make of that. So if you have a thickened cord, sometimes you can clinically have some function, and that you get in there and it'll stimulate, but it's abnormal on MRI. So it's, I think, fairly sensitive, but not necessarily specific on some pathologies. I think for more distal nerve injuries, ultrasound is really an opportunity for growth for our practice. Somebody on the chat was asking about the use of ultrasound for gunshot wounds. And unfortunately, we have a lot of gunshot wounds in St. Louis that we treat. And it's not an uncommon scenario that people come in and they have a neuropraxia or some sort of axonotmetic injury, and trying to identify if that's something that we should intervene on, if it's more of a neurogenic picture, is difficult at times. And so the classic teaching of that it's just a blast and it'll get better is really not always proven to be true for us. So we use ultrasound preoperatively. The one I showed was a preoperative image to help us to decide to intervene sooner I think what we would have normally. We've not used as much in brachial plexus, however.
Yeah, I totally agree. And for me, MRI has really changed my practice. How about you, Terence? Do you have any comments on this? New things which should help your practice?
Thanks, Howie. I mean, I echo all the thoughts of the panelists about this distal nerve transfer. I think that's the way the practice has been changing since we practice the distal transfers. I think that's definitely a role in brachial plexus injuries. Apart from that, I think what we need to understand is all those distal nerve transfers do not work well, of course, in different hands.
Wait, hold on a second.
I'm sorry.
Oh no, please go ahead. Yeah.
I think there may be some outcome difference in between surgeons who are operating. Because I've seen same distal transfers working well in some patients and not working well in other patients. Obviously, I need to go for a tendon transfers. That's quite cannot be understood. The reason behind why the results are varying between patients of the same injuries, who does well in one particular part of patients and then does not work well in other particular patients. I think that needs to be understood. Apart from that, I think distal transfer are definitely the role of the current concept in treating such injuries. Johnny, please go ahead. You have some comments.
Oh, no, sorry, Terence. I didn't mean to cut you off, but I'm really intrigued by David's lab work. I think that's going to be revolutionary. That's if you really get that to work in clinically. One thing that people come to mind is like partial or Sunderland 3 to 4 injuries, but going back to this nerve transfer thing, I think one of the reasons it doesn't work is when you have an injured donor nerve. And I think Chris had a really good, Chris D, I think in another meeting that we had brought up when you had CAT1, that C8's injured, but it's still recovering, but you're kind of having dilemma if you want to operate early or wait for the donor to come back. And, if David, if you could get that imaging to work on that donor nerve and show that it's a functional nerve, it's just waiting for it to recover. Again, that's going to be like ICG, for free flaps. And like, you're going to be like Nobel Prize in nerve injury. I really, really, really mean it. So I'm looking forward to that. I just really thought that was like one highlight today. Yeah.
I agree. That's really so exciting work, David. I'm really looking forward to seeing, what comes out of your lab as well in the future.
Thank you. That's very kind. I appreciate it. Feel free to tell the National Institutes of Health that. Well, committee cheerleading. I think that hopefully there are some better ways to evaluate nerves intraoperatively. It is a challenge for us and continues to be for those kind of partial nerve injuries or axonotmetic injuries, for sure.
I want to try and get through some of these questions because there are a lot of them in the chat. So we'll try our best to answer everybody's questions. First question from Dr. Mir Mohsen is, what is the upper time limit to go for nerve transfer for preganglionic panplexus injury in a 40-year-old patient? I think maybe I'll rephrase this question as to, when would you explore preganglionic injuries and when will you do nerve transfers? So for me, I don't routinely explore injuries when MRI suggests it's all preganglionic avulsions. I don't know what the rest of the panel thinks, unless the MRI suggests there's at least one viable route. And if I do explore them, try to explore them within 6 months of injury. Otherwise, I'll go straight from nerve transfers. What do you guys think?
So I'll just answer from my perspective. I explore everything. I don't necessarily, even though we have a really MRI team, I explore it and then decide what I want to do. And also we do we use phrenic nerve in addition to spinal accessory nerve. So again, even if it's a route that doesn't look so good, I'd still use it, but I use it in conjunction with another donor nerve to add axons. And it's unexpectedly, sometimes it gives you that extra bit of function. But I think it's justified to not explore and do a distal, posterior approach, spinal accessory to suprascapular. Yeah, that's my perspective.
How about you, David, Terence?
Yeah, I would agree with what Johnny said. I'm fortunate that Chris and I do these together, and so it gives him something to do and keeps him out of my field on the clavicular plexus. So he's very good at it, and so the extra morbidity and the time for us is not as much because he's very facile at getting those out and finding them. So it is impressive how we often will find something, even when the MRI is not suggestive of a great outcome, we can usually find something to graft to, which is nice. And so we tend to do it, but I agree that it's certainly there's clinical equipoise for either solution.
Yeah, I too agree with all of your thoughts. And then what is really perplexing is that when you open it, the brachial plexus at the supraclavicular level, what really amazing was that you find a completely good-looking nerve, especially the C7, but then it's not stimulatable. We had many occasions where we found a good nerve, even up to this, the transverse process up. And then when you stimulate, it is not working at all. So that was the one thing which is always making us difficult. Apart from that, I think I completely agree with all your thoughts. It has to be explored, and whichever route is available in a good condition, I think need to be transferred. Probably David can comment on this patient, in cases where a good-looking nerve but not stimulatable. I think your research study would definitely be helpful, in making a plan on such cases.
I totally agree with those comments. This again re-emphasizes the importance of exploring the plexus. I will say I've been in the other situation as well, where the MRI suggested there was a graftable route, and then I explored the plexus, and the whole plexus was retracted distally, and it was all avulsions. So I think it really goes both ways. And for me, I really only would not explore if the MRI reads a 5-root avulsion, but I can certainly see the argument for exploring as well and trying to see if you find something.
Going back to that question, upper time limit, what would you guys do? I think anywhere less than a year, I'd still try to do a nerve transfer. I know it's not optimal, but again, I would say if it's 6 to 12 months, again, I really enforce that, especially in the panplexus, I preserve that spinal accessory nerve, because I always have that back in my head that I'll probably just do a functioning free muscle somewhere down the line. And any cases that has not been operated on or has not been treated past 6 months, they usually have really stiff joints. So again, doing that nerve transfer, you need to be careful. Yeah, you try to get that loose, and maybe there's something with that nerve transfer. And something I learned from Dr. McKinnon is looking for fibs and positive sharp waves in the EMG. Again, this is something that I think none of us really mentioned today, but electrodiagnostic studies gives you really, really good information, especially EMG, on your target muscles.
I totally agree with you, Johnny. And actually, I think for some nerve transfers like the Oberlin, there have even been papers published that show, like there's a paper in Hand that came out not too long ago about results following for Oberlin after 12 months from the injury, and they showed good results. And we know for some patients with AFM, acute flaccid myelitis in children, Scott Cozen and some other people have showed you can do these Oberlin nerve transfers really late. So really, I think if you're able to do a nerve transfer, it's really the only shot. I would do it, but I wouldn't probably explore the plexus past about 6 months. That's like my guideline.
Yeah, I think that's reasonable. I think the one thing I would caution with the AFM and those kind of more proximal lesions is that it's slightly different. If it's an upper motor neuron or something, and so I don't want to give the impression to the attendees that it's a different bag. It's a totally different lesion basically, and so those you can get very late for sure and have great results. I think the only thing that sometimes influences us, if we're deciding between doing a free functioning muscle for elbow flexion versus like a intercostals to with a graft or intercostals to musculocutaneous, if it's starting to get a little bit later near that 1 year mark, we might tend more to kind of just jump to the free functioning muscle because we've had fairly good results with that in the right patient population. But I agree that I think that there's not a strict time limit up to a year. I think that you might as well try because there's usually not many other great options for these patients.
I think I want to point out one more thing about intercostals. Intercostals as well, I think it's well known, take a bit longer to re-innovate. So I think that compared to like Oberlin, for example, so if you're going to do intercostals, I would try and do them early, definitely.
I think the intercostals, again, if you're running into that sub-optimal timing, I think the way that I've seen Professor Chong mention this before, but also Alex Shin, who obviously published on this, doing that combined nerve transfer with functioning free muscle, since you don't want to waste that donor site, that recipient, I'm sorry, the thoracodorsal vessels, you don't want to go back in again later on. So if you want to preserve that that site of undissected vessels with your musculocutaneous nerve, with your intercostal nerves, do that combination, which I think is a good option.
I think that on that regard, the paper that came out of Mayo actually showed their equivalent outcomes when they did a combined functional muscle of the intercostal together with the intercostal musculocutaneous compared to only the functional muscle alone. So at least the Mayo literature suggests that if you're not going to do a nerve transfer or something for a complete plexus, you should just do a functional muscle. So I think that for me, at least, that's been a consideration for pan plexus injuries.
Thanks for clarifying that, Harvey.
Of course. Well, let's see. We have another question. There's one question on Dr. Nguyen from Vietnam was asking about what do you think about the combination of a spinal accessory to suprascapular nerve transfer and radial nerve to triceps to axillary nerve to deltoid of the posterior approach. So I think maybe the question I could rephrase as, what do you guys think of the spinal accessory to suprascapular nerve transfer from the posterior approach, as opposed to the anterior approach? Do you guys use it in your practice? And if you do it, when do you do it?
Yeah, I'll just start. I always do the anterior approach. It's because we most often explore the plexus, so it's better that patients in supine position. But I think if you're deciding not to explore, I think doing the posterior transfer would technically give you a better outcome since you're closer to the target. And also there's this incidence of where the suprascapular nerve travels from the anterior side, going down the notch, going to the supraspinatus and infraspinatus, that it might get injured somewhere there. So I think posterior approach is something that I don't do that often, but I think from the results that I've seen everywhere, it seems to be a good outcome, but I do anterior approach.
I would say that we have a similar algorithm, but if we're doing for a pan plexus or somebody with a more than just kind of an isolated upper trunk, then we would do an anterior approach and then transfer it there. But for kind of convenience and practicality, if it's more of an isolated upper trunk, which is admittedly more rare in our practice, then we'd probably skip the exploration of the plexus.
It's 9 o'clock.
We would go straight to the posterior approach with the nerve transfers, the radial to axillary and the spinal accessory to suprascap. And that I think works well because you'll get closer to target. And so to us, there's no real benefit to getting grafting from a root in that situation. But it's a rare indication for us.
How about you, Terence?
Yep, we have a study, and I've submitted this article to Journal of Hand Surgery, comparing the outcome between anterior approach and posterior approach. Obviously, we didn't find any statistical significant outcome differentiation between these two approaches. What we could comment, or what we found very interesting is that in posterior approach, what they claim is the distal transfer, more distal most transfer. Say, for example, the spinal accessory to suprascapular, or even the Somsack approach. The distal transfer also work equally well when you transfer the nerve more proximally, meaning to say that there's no difference between distal nerve transfer and the proximal nerve transfer. That's what our study focused on that. So, for example, I tell you, we do a long head triceps branch to axillary nerve through posterior approach. Meaning to say that you're going to target very close to the donor nerve, the donor and the recipient. But then we do also the anterior approach by anterior pectoral, and then we find the long head triceps branch and the axillary nerve. We transfer it here. The outcome is different, and the outcome is not different. Usually, what think is that the distal transfer do well compared to the proximal transfer. So this is the outcome of our study. I think both approaches do well. It depends upon the surgeon's perspective. Overall, we didn't find any statistical significant difference in terms of outcome, motor recovery, and the functional return to work. I think that was the study conclusion. We have submitted to Journal of Hand Surgery. Probably it's under review now.
Well, those are all great comments. I'll say that for myself, if I do a triple nerve transfer for upper plexus, I tend to do it from the anterior approach because I don't like turning the patient over. You can do the oberlin from the front, you can do the triceps to axillary in the axilla, and the spinal accessory to suprascapular up, in the supraclavicular plexus. Where I've used the posterior approach for is sometimes I've explored the plexus, and in a few cases, everything's avulsed and retracted distally. Then I'll bring the patient back to do a spinal accessory to suprascapular transfer from the posterior approach. So that's been my specific algorithm.
I remember talking about this with Dr. Somsack, I'm sorry. And he's obviously done so many of these combinations, and he actually mentioned he prefers the anterior approach more, and he had similar outcomes too with anterior and posterior. So I think posterior makes sense, but it just seems that anterior is giving out as good as an outcome. But I just wonder about the time though, time to reach shoulder abduction. Terrence, in your series, did it take longer for the anterior approach, or any of you guys, Harvey and David?
In our series, I think there was a subtle difference between the anterior and the posterior approach. Posterior approach was earlier to get the motor recovery, but then overall, the statistically doesn't have any significant difference between the final outcome. So, for example, you look into the posterior approach and get the shoulder abduction or shoulder rotation, time to recovery. It was earlier than the anterior approach, but then overall, the outcome and the long-term follow-up were quite similar in both those approaches. What I need to stress on this is not differentiating the surgical approach, but what I stressed is that even the distal transfer do work similar to the proximal transfer. This is what I want to convey in this article.
Thank you, Terrence. I'll cite your article soon.
yeah, I look forward to seeing it. I tend to agree as well. I haven't seen a significant difference between the anterior and the posterior approach. Dr. Aaron Berger has a question, specifically for David. Great studies, Dr. Brogan. Can you provide some advice on how best to deal with the all too common neuroma and continuity that we see in closed and sometimes open injuries? Are there studies you use pre-op and intra-op to help decide what to do with these? So we kind of touched upon this a little while ago about the exciting studies that you have. But I guess maybe a segue into a question would be, how do you guys decide whether, when you explore a plexus and you see something like a neuroma and continuity, how do you decide whether to cut it and graft it or whether just to leave it alone? So I love to hear from the panel.
Okay, David, please, you go first because this question is yours.
Oh, no, it's fine. And I apologize. I'm going to have to probably answer and then sign off. I have some family obligations.
Yeah. Okay, go.
But it's a great question. And it's something that bedevils us. The neuroma incontinuity is one of the most challenging things. It's a lot easier if you open it up and the nerve is transected because the decision-making is easier. It's technically much easier. I really struggle with the patient who's had the poorly done carpal tunnel release that is half the nerve is transected and scar, and then the other half, they still have some function. Those are just nightmares because you have to dig through concrete to try and dig out the fascicles. What we tend to do is look at intraoperative stimulation, either with kind of formal studies and electrophysiologic monitoring or just a nerve stimulator to see if we have fascicles that are in continuity. And if you feel strongly that the patient has on their clinical examination some function of the nerve, then I would tend to not just cut it wholesale and resect the neuroma because I want to preserve whatever function they have. And in those cases, I bring in the scope and I take the micro scissors and I just start dissecting out, open up the nerve proximally and distally, do an internal neurolysis and look for what seems like intact fascicles and try and tease those out and keep them, and then cut out what is just scar and damaged fascicles. And it's painstaking, it's frustrating, and it's nerve-wracking as well. But I think for me, this is the thing that has worked probably the best. But I don't have a magic answer for that, unfortunately. It's just seeing what you can do. So, all right, thank you all very much for the time, the opportunity to chat, and best.
Thank you, David.
Thank you, David. Thanks.
Yeah.
Thanks, David.
Yeah. Well, Johnny, how about your take on this?
I've had really bad experience with this. Yeah, I've had a patient who was a bit younger, but she had some sort of shoulder abduction, probably like 30 to 40 degrees. And then I did something to their I ended up resecting that neuroma and then doing a nerve grafting on it. And then she lost all that. And her parents were furious. So I think I think that what David said, it's something that's, it's applicable to every one of us. I just want to add to that is that having a good patient communication, because having that shoulder abduction 30 to 40 degrees is not going to help much, and if it's an acute enough injury, and even if it's 30, 40, overall outcome is still going to be poor. So unless you can do something to augment it somewhere down the line, but for shoulder, it's very difficult. So again, I just wanted to add that similarly, I think documentation is also very important. Every time you see the patient, the first time you see it, you have to document very well so that the second time you see them, maybe a month later, you see a slight improvement, which might give you a hint that something is going through, that this neuroma is worth preserving. I think if there's nothing, second month, third month in your electrodiagnosis studies is kind of telling you that there's, a minimal amplitude, like maybe 0.1 or 0.5, even at 5-6 months, then I think it's worth it, just go in and resect the thing. But again, I want to emphasize that you have to do your PE well, you document well. And then if you decide to take it, be ready to explain to the patient and the family that you might be taking out something that they might already have. So that's my, and then another thing is, I think with the use of supercharge or end-to-side, I'm a believer in that. And so it depends on what nerve you're talking about. But if it's a muscocutaneous nerve, it's a neuroma in continuity, and there's some elbow flexion, something with that biceps, and maybe you could do something end-to-side more distally, or maybe just take out one of the biceps or brachialis. That's my take, or do functioning free muscle somewhere down the line. Sorry, it's a bit long.
No, it's a great answer. How about you, Terence?
I think additional to all those views, intraoperative stimulation from the location. If you target a particular, for example, you need to look for the muscular cutaneous in the biceps. If the neuroma is intact, biceps is working, I think I would not do any resection on a nerve grafting. If it's not working, probably I'll go ahead and do a nerve grafting, resection and nerve grafting. It all depends upon the location and type of.
Oh, we can't hear you, Terence.
Can you hear me now?
Yeah, we can hear you now.
Yeah, I'm sorry for that. It is a tough decision for surgeons, especially when operating on the brachial plexus injuries. What I was trying to say is that additional to those views from David and Johnny, I think intraoperative stimulation and the location of injury. Say, for example, you have a neuroma in continuity with muscular cutaneous nerve, probably you could stimulate. And then if you find the biceps is working, I think there's no need for surgery, excision or grafting. If you find that it's not working, probably excision and nerve grafting will definitely help in situations. It all depends upon the location and the injury pattern. Addition to views of Johnny and David.
So I totally agree with all those comments. And for me, at least, imaging is pretty important. So if the MRI shows like a nerve in continuity, I tend to wait a bit longer before exploring. And then absolutely what you all said about the intraoperative stimulation. So I think it would be ideal to have intraoperative electrophysiology, like to do nerve to nerve and SSEP and all that. In my practice, it's difficult because I tried to use it for a few cases, but it's just very difficult to get it set up. So I use the checkpoint nerve stimulator and stimulate the nerve. And if there's firing, I tend to preserve the nerve. And absolutely what you said, Johnny, about the supercharged end-to-side. I've done it for SAN to SSN and even for Oberlin. And I think it does work when you're not sure, if there's any conduction across the nerve. So all great points. There's a question from Dr. Lysak again about, do you use lipo filling for brachial plexus surgery? And do you use bone marrow BMAC injections? I presume that's bone marrow adipocyte cell injections in denervated muscles for preservation of target muscle. So I do not. Do any of you use lipo filling or stem cell injections? No. Okay.
I haven't.
No, I don't.
And then we have another question from Dr. Nguyen. For Johnny, how long is the waiting time of the patients you did vascularized ulnar nerve graft after diagnosis of BPI?
When do I go in? When do I do the exploration? Is that what the question is?
I think it's asking. I think maybe it's the question should be, how long after the injury would you perform a vascularized ulnar nerve graft?
Okay, that's a good question. I think since I've mentioned this in my talk, and that there's been people have been saying that when you have a vascularized nerve graft, you can wait a bit longer. Actually, I do agree with what Harvey said about neuroma in continuity, or if there's hints or signs that there might be some improvement or anything. But before I decide to do a vascularized ulnar nerve graft, number one priority is that the hand doesn't recover, or there's no hint of any, no hint of that ulnar nerve coming back. And if you have an MRI, we try to do our MRI around the 3rd or 4th month, definitely not acute. And if it shows that the CAT1 is avulsed, then pretty much I'll jump in right away, because I want to get the most perfect setting for my nerve grafts to work. So thanks for that. But I agree. There's variability in the time. Some people wait a bit longer, 5 to 6 months. But for me, I try to go less than 6 months for sure.
Okay, great. Thank you. So we have another question actually from Dr. P.S. Bandari as well as Dr. Zagar about neuropathic pain in plexus injuries, which is, you can have a whole talk on it in itself. So, either of you guys, would you like to talk about how you manage, or maybe let's focus the question and maybe let's talk about the role of a nerve grafting in the management of neuropathic pain. What do you guys think about that?
I in my patient population, it doesn't help. I think that the pain goes away after the patient. It goes naturally with their injury, with how they adapt to their injury. That's what we tell them initially. Every time we do the reconstruction, and I think what Chris was mentioning before about the outcomes. Something that's you have to emphasize before you do your surgery is that the pain doesn't go away after your surgery. And if you don't tell them that, they're going to consider the surgery a failure the second they meet you after the surgery. So that's my perspective. But somehow I think there's something with cortical remodeling with the pain. We don't do really anything for the pain. We tell them kind of, we have these patient support groups in our social media that we help them explain this types of pain. Definitely, even cases that do contralateral C7 with total root avulsion, they actually don't have a higher degree of pain. But the coping of the pain, I think for them, it's important to get other patients' perspective. But again, going back, surgery doesn't help or anything that we do. Yeah.
How about you, Terence?
I think in our study, I think most of the patients, they do have certain perceptible improvement in the neuropathic pain. Obviously, we don't have any answer to that. As Johnny was saying, something particle remodeling, it's beyond our imagination, incomprehensible. But certainly, yes, most of the patients, they do feel better, especially with neuropathic pain when you do a surgery and nerve grafting. I think it's our series of quite different.
I think anecdotally, I feel that nerve grafting helps. Like nerve grafting I found that in a post-ganglionic injury with positive Tinels and neuropathic pain, when I do perform nerve grafting, I find it helps somewhat with the pain. It doesn't make it go away, but patients do feel better. But I think avulsion injuries, pre-ganglionic injuries are very hard to treat. And there's some people out there who perform like DREZ ablation and things like that, but there's a lot of morbidity of that. And I think not everybody is comfortable doing that, and also depends. I think most often this will be done by a neurosurgeon. So unless you have a neurosurgeon who's comfortable with operating near the spine and your patient understands they get permanent disability and paralysis, then it's really a very difficult option to offer them. But I've also seen patients where that has worked in helping with the differentiation pain. Okay, let's see what other questions we have. So there's one question from Dr. Naik Nishal about posterior approach is best in case with scapular neck fractures. Always go for posterior in those cases. Okay. Any of you have any comments about that? I presume he's talking about the spinal accessory to suprascapular nerve transfer.
Those are certain indications for the posterior nerve transfer. I think, as I'm mentioning about the indications are and the surgeon's perspective, it all depends upon surgeon's wish. Even a normal brachial plexus injuries, many surgeons prefer to go posteriorly to do nerve transfers, even in upper brachial plexus C5, C6. Certain indications definitely do help. So one such as the scapular neck fractures, I think definitely will help us.
Okay. And do you have any comments, Johnny?
No, not really. Yeah.
Okay. And there's a question from Dr. Baraf Kadadi, comment on partial versus total contralateral C7 transfer. So I think you answered this to some extent, Johnny. I know you guys like to use the total contralateral C7, but do you have anything else to add?
Yeah, I think definitely if you have concerns about it, I would go for the posterior division of the contralateral C7. But again, I think once you've decided to do contralateral C7, I trying to go for the most optimal outcome is more important than trying to. I think there's been very variable data. I think Tertzi's published a very large study looking at hemi versus whole. David also published on this, but from what I've been taught from David is that doing a complete, complete total C7 is just better functionally, and there's not that much donor side morbidity. Yeah, but
Yeah.
I think, yeah. Oh, sorry. But I think a more strict, like indications of using the contralateral C7. I think again that's something that you need to at this day of age. Everyone worries about the donor side morbidity, and so it's justified. But it's just from our instances, from what we've seen, and including qualitative studies that we've done, we just haven't seen that that significant donor side morbidity. But this has to be for total root avulsion, and for these patients that have nothing, especially if it's a right hand or the dominant hand. Yeah, I think using something from the healthy side, I think is justified. Yeah.
I think this issue about contralateral C7 is that you guys get such great results as well as our colleagues in China, but unfortunately nobody around the world has been able to replicate those results. So hopefully that, maybe that will change, because really I think what we see that everything is cyclical. So same for brachial plexus injuries, it seems to go back and forth between non-vascularized nerve grafts, short and long nerve grafts, and maybe the contralateral C7 again, and maybe in the future things will swing back towards contralateral C7 again. So I think, yeah, things just keep evolving.
Thanks, Harvey.
Yeah, there's a question from Dr. Naik again. Can we take cervical motor branches along with hypoglossal instead of contralateral C7? So I guess this is directed to you as well, Johnny. What do you think?
Yeah, I think, we call them the CMB. I think with Dr. Wolf, his recent study in JHS, he was talking about the levator scapula as a donor nerve in cadaver studies. But the cervical motor branches, that study, the problem that we've had with that study is that the levator scapula becomes very, very thin. And I think with Harvey and Terrence, I don't know if you can support me on this, but they become even if they're motor, they become very, very small. And they really are able to reach that suprascapular nerve or the posterior division. So again, the axon count with that, I don't think it's enough or justified. I think it can be used to augment. But going back to what I had presented, we use the contralateral C7 mainly for hand. That's our primary goal. So I don't think the CMB nor the hypoglossal has enough axons in there to really going long and deep, going into the median nerve, even if we have and looking at the size and the caliber of the vascularized on nerve graft, I would not use the CMB nor the hypoglossal. And I've had really poor results of hypoglossal. I tried it, after discussing it with David, and I felt like, a little bit booby trapped. I just had bad results. Yeah.
I totally agree. I've not tried either of these, but I've talked to people about the hypoglossal, and similarly that I've been told it's bad results. How about you, Terrence? Any comments?
Yeah, I haven't tried both either.
Okay.
But I want to mention, in the field of facial reanimation, people are using the hypoglossal to add tone to the mimetic muscles, and they're seeing the similar effect with the crossface as with the hypoglossal. So that's very interesting. So if you're thinking about using the hypoglossal, I think there's growing support for it to be used for the facial nerve. Yeah, and so it may be like a dual innovation with your masseter. And that I still wouldn't abandon. I think hypoglossal is a good nerve. I just don't think it's enough to get you that excursion in the brachial plexus.
Yep, totally agreed. We have a question from Dr. Berger. And Aaron, if you're online, please feel free to turn on your video. He's asking for forward avulsion, upper trunk and contralateral C7. So I'm not very clear as to what you're asking. Are you asking what to do if there's a forward avulsion?
I think Johnny already answered the question. That was what he does, which is focus on transferring the contralateral C7 to the hand. And the question would be was what to do with the remaining good root from the upper trunk.
Okay. You mean if you had forward? Oh, okay. I wouldn't use the contralateral C7 if there was a root on the injured side. If it's so I would only use it, or if that root, the C5 was, like partially avulsed, Again, I would not use that for the vascularized ulnar nerve graft. So I would probably combine it with the contralateral C7. A good question, but if it's a 4-root avulsion or if you have that intact root with the C5. But if it's vice versa, if it's C5 to C8 root avulsion, when the T1 is there, yeah, I would not use that. And I think I really like the Harvey's technique that you mentioned today.
So I think I would add to this. So Aaron, I guess the right question is, I mean, it differs whether it's a BPBI or adult brachial plexus injury, right? So if you have one graftable root like a C5, which is most commonly what you'll get in adult brachial plexus, or graft the musculocutaneous nerve, because that's the most important. But for BPBI, if there's one root, you know, as we both have discussed and learned, you know, from our mentors, we'll graft to the medial cord, which goes to the hand, because hand is most important for BPBI. And then you could supplement with whatever spinal accessory to suprascapular or some other nerve transfer in the extra plexal area that you would do. So that would be my approach. Any comments, Terence?
Perfect. I think I agree with this. Differentiating between the brachial plexus birth palsy and traumatic in adults. Most commonly, we see C5 intact nerve root. Probably can give this to musculocutaneous. And for the children with the pediatric, I think you need to target the middle cord. That's more important.
Okay, great. And one final question. Dr. Baraf Kadadi is asking about long-term morbidity after phrenic nerve transfer. He said he stopped it totally after a patient ended up in ICU 6 months post-op phrenic nerve transfer. So maybe this is for Johnny again, since you're probably the most experienced with phrenic nerve transfers among our group.
Yeah, I think this is an interesting topic. This is something that we've been publishing before, but recently trying to get more in. I think phrenic nerve for us is something that we use very often. But again, in Taiwanese patients, there's a study that we've done actually with the Mayo group that's going to be published, hopefully, looking at the demographics of 100 Penplex patients or total palsy patients, whether it's root rupture, one root, or a total root avulsion. The BMI was significantly different. And I think we talked about this with Harvey. We've talked about it with the BMI. There's the contraindications definitely with the phrenic nerve. Obesity is one. I think child definitely is something that you don't want to use. If the patient has any respiratory problems or obstructive sleep apnea. So I don't know what happened with Dr. Kadadi's patient, if the patient was indeed have any of those characteristics. If not, if the patient does fall under the, like a young patient, which most BPI patients are, we've had use of phrenic nerve with the intercostal nerve. But be careful when you do a phrenic nerve, and then you're also doing a contralateral C7 dissection. Be very, very careful not to injure the contralateral phrenic nerve or even have a neuropraxia of the contralateral phrenic nerve. It happens. So for me, when we do the brachial plexus exploration, as you had seen, we do a very wide, big C-shaped incision. And that is the primary aim, is that one of them is to protect the phrenic nerve too, before we actually use it. So yeah, I think these are factors. I don't know what happened with your patients, and it's unfortunate. We tried to publish in JHS. It's still undergoing revision for the 3rd time. And we changed the topic from reliable to alternative. And I think the editor is trying to go a way around it. But yeah, again, I want to emphasize that phrenic nerve is a reliable alternative to the spinal accessory nerve. And there are reasons for that, for us to not use the spinal accessory nerve that often, because it's a really powerful nerve. Yeah.
So that's all great points. So I think we managed to get through all the patients and all the questions, and we're coming up on 2 hours. So thank you so much, everybody, for attending, and thank you so much to our great panel. Those of us who are left, Johnny and Terence, thank you so much.
Thank you.
Steve, Chris,
Harvey, Terence, great meeting you guys. And thanks everyone.
You guys, and we'll catch up again in person sometime.
Yes. Thank you.
All right. Have a good weekend. Take care, everybody.
Yeah. Bye.
Yeah. Bye.